We have Cindy Romer, who actually has Tim's shoe that has arrived here in New Jersey. So yay, yay. Sounds like Miss America, right? And she's going to give you a little bit of history, and then we're going to go into the doctor's talks. Start talking.
Okay, thank you. Okay, so let me just say really quickly, I spoke about MSA New Jersey. I had the chance to meet and chat with a few of you over the lunch break, and I'm glad to have the opportunity to do that. If some of you didn't get the chance to talk to me because it was pretty busy, you can reach us through the webpage, and you can email me there. I also want to tell you that we have a Facebook page, and please like us, and please like Pam Bauer is a dynamo, and she's got MSA.org, and her Facebook, Miracles for MSA, and Shai Drager. And I just want to say this as a practical point. It really helps to like those pages. It does two things. It gets the word out there and spreads awareness. And it helps to have those numbers as we try to get sponsors and we try to get awareness and we try to get articles written to say, go look at these pages, there's a need, there's a group, we're a community, and we need to be heard. So please get out there and show support to all these people that are working so hard. And speaking of working hard, Judy and Vera have been thanking everybody. Judy and Vera, you guys deserve a round of applause for all your hard work for what you do every year. Now, so speaking of Facebook, Tim's shoe. I think everybody in the MSA community knows Tim's shoe, at least those of you online and in Facebook. It started as a practical joke, a prank with Tim's shoe, and it became something that's now done as spreading MSA awareness. So Tim's shoe has traveled around the world. He's recently been at the Olympics. Just this past week, he's been down at the Jersey Shore, having a good time, kicking up his heels in the sand. Sorry, couldn't resist. Dancing last night, and he's going to continue his world tour after he leaves New Jersey. I have to pass him off to Kathy, and he's going to Canada, and Kathy and I actually, have pictures of us fighting over him on the dance floor last night, so we got to watch her. I want you, each and every one of you, to have a chance to mingle with this celebrity, Tim Shoe. So what I'm going to do is pass him around the table so everybody can touch him. And when Tim Shoe has made his way all the way around, I'll take him back outside on the display table so it's out there before you leave, before I have to hand him over to Kathy and see him, bid him adieu going off to Canada. And those of you, as it makes its way around, if you take a picture, please email it to me so we have it and we continue to put them up at the site so that we can show this awareness up at Where is Tim's Shoe? All right, thank you.
Thanks, Cindy, very much. Okay. The only other thing that I really have in the last packet, the last piece of paper in one of your packet sides is an evaluation form. It is very important to us that before you leave this afternoon that you fill out those forms. Be brutally honest. I mean, we hope it can be all happy faces and stuff, but we know that sometimes you encounter a problem. So give us your compliments, give us your complaints. Only by your being honest and giving us your good feedback can we make next year's conference as good as or better. And just, if you have suggestions on what we could do, like before we've never had a medical supply equipment company come visit, so if that was helpful, let us know. Just, we value your feedback. So, and that being said, we are going to get the doctors set up and the therapists set up to give their talks. So, and first up is, when Cindy quits talking here, is Dr. Amy Colcher, and she is officially our physician host for the afternoon. So we all welcome Dr. Colcher. And you can sit or stand.
I don't know what I'm going to do. I'm going to wander around here. It is great to be here. It's great to see so many people here this afternoon, and I'm sorry that I get to talk to you first after lunch, because lunch is what makes me tired usually, and so I hope that I can keep you awake with a little bit of a research update. So what I want to do at first, before I start into specifics about research, is to just give you a sense of what research is, what clinical trials are, how we conduct research, what kind of rating scales we use when we're studying therapies for MSA, Just a little bit of background in that sense. I think that sometimes research gets bad press, that people feel like they are being used as guinea pigs, and that there is no safety measures in place when people participate in research, because it's all about, you know, drug companies making money, and it's not really about patient safety. So I wanted to sort of go over a little bit about what research entails. Typically, the research that we do when we're looking at a disease like MSA, which is not as common as certain other diseases, the first type of research that a lot of people will do is called epidemiological research. So they're looking at things that are potentially risk factors for MSA. They're doing a lot of questionnaires. They're doing what are called longitudinal studies, where they follow people long-term with the disease to see how the disease progresses, to see if there's stuff that they could potentially find in the blood, on an MRI scan, in spinal fluid that would help us to make a diagnosis or to help us to learn more about the condition. Those studies do not offer any therapeutic benefit to the people that participate. They are there to help scientists learn about the condition, but I think they're also wonderful to participate in because they allow you to feel like you're doing something that aids us in caring for people with MSA. I have to say that we participated in a big study, one of these studies where we followed people with MSA for years and years and years, and we did rating scales on them throughout the course of the disease, did blood tests that were sent off and analyzed, and in the end, many of those patients were willing to donate their brains for study as well. So just in terms of my own personal experience, we had a lot of questions this morning about how do you make a diagnosis of MSA? What is is there a definitive test that helps you to make this diagnosis? And you heard that the imaging studies that we have that look at the dopamine system, they don't help to tell us whether it's MSA or Parkinson's disease. They just tell us that there's something wrong with the dopamine system. And really, the only way to know for sure is to look at somebody's brain under a microscope. And I know somebody said that it was safe enough to do a brain biopsy while people were alive, but do you really want somebody taking a piece of your brain while you're alive if it's not really going to change anything? So we don't typically do that in order to make a diagnosis, but we do use the information that we get from people who are generous enough to donate their brains after they pass on to help us learn things about MSA. And MSA is it sometimes is very, very difficult to diagnose. And you follow people, and I can tell you from participating in that longitudinal study myself that we had a patient in that study that when the pathology came back after he had passed away, the pathology was just regular Parkinson's disease. There wasn't MSA in his brain, even though he had had all those diagnostic criteria. He had had orthostatic hypotension and erectile dysfunction and pretty much couldn't sit up without passing out by the end of his life, swallowing dysfunction, and Parkinsonism that didn't respond to any medicine. So you can definitely be fooled, and it is those studies that allow us to follow people long term that will help us in the future at making a better diagnosis, at making a more precise diagnosis, so that when there are more therapies that are specific for MSA, we can make an early diagnosis and hopefully implement those therapies early in the course of the disease rather than waiting until it has progressed to such a degree that the person with it is more significantly disabled. So the longitudinal studies are safe because you're not being exposed to any compound that we don't have a lot of information about, but the benefit that they provide you is more of an altruistic benefit, that you're helping us all to learn about the disease process, not necessarily that you're getting a therapy that is going to make you feel better. The next kind of study that we do are studies that actually look at therapies for the disease, whether they're therapies that could potentially slow down the progression of the disease or therapies that could potentially treat the symptoms of the disease, and some of them are geared towards specific symptoms of the disease, like orthostatic hypotension, like Parkinsonism, like memory problems, like mood problems. So you can target one specific symptom, or you can target sort of overall symptom progression in MSA. The way studies are typically done when we're looking at a drug and we're trying to find out if it works is that drug studies are initially done where the drug is tested in animal models. They use some kind of an animal model of the disease. We have mouse models of multiple system atrophy, and we test drugs in those experimental models, and then we move on to human models. We try the medicines out in healthy volunteers first, and then we try it out in small numbers of people with the disease, and then we try it out in bigger numbers of people with the disease. But the idea, the main thing that people are very, very cautious about, and I know in my work with clinical trials for all different types of movement disorders, the thing that we take very, very seriously is patient safety. And so there are external monitoring committees that look at all the laboratory data, that look at all the data we collect. They don't wait till the study's all over to see if the data looks funny. They look at it very frequently to make sure that there are no abnormalities that are making us feel that the study is not safe. And I have been involved in clinical trials where the study was stopped in the middle of the study because something showed up, either in testing on the volunteers or in subsequent animal testing that showed up later than when the human studies had been started, where the studies were stopped because we weren't sure if that was going to be a danger to the people that were participating in the trials. And until that was sorted out, they would not expose anybody else to the experimental compound. So that is something to keep in mind, that somebody, when you're participating in a trial, there are tons of safeguards to try and make sure that that drug is as safe as possible and that you are as safe as possible, even though you're being exposed to a drug that has not yet had FDA approval. So that is in place there, and that is something to consider. The other thing that I think that we don't all think of, we think, okay, there's this experimental drug for MSA, I want to take it. The truth is, it's experimental because we don't know for sure if it works. So that participating in a clinical trial, there's a chance that you might get placebo, you might get fake medicine and not the real medicine. Sometimes people don't want to participate because there's a chance that they might get fake medicine. There's nothing wrong with fake medicine. There is something that's called a placebo effect, so that when you participate in a clinical trial and you're given a drug that might help your condition, even if you don't know whether it's the real medicine, and I don't know whether it's the real medicine, but there's a chance it could be a medicine that will help you, over a third of people who participate in those studies will feel better anyway, whether they get the fake stuff or the real stuff. And when we're talking about a condition like MSA, which as of right this second, there is no treatment for, there is no cure for, if 30% of my patients are going to feel better if I just hand them a bottle of pills that are made of sugar, then I'm all for that. I'm happy if some people feel better. And I think that that is something to consider when you are thinking about participating in a clinical trial, that the real medicine may or may not work, the fake medicine may make you feel better, and participating in a clinical trial makes you feel good. You get a lot of care from the physicians, you get sort of extra attention from the staff at the place where you participate in the clinical trial, so I think that that is good for everybody. And you know that the people that are running that trial are sort of really up to date on what kind of research is being done for MSA. So I think that those are all good reasons to consider participating in clinical trials. The way that we evaluate whether a drug works or doesn't work in MSA is using the Unified MSA Rating Scale. That's what the UMSARS stands for. And this is a rating scale that has 4 parts. The first part is historical, so we get this information by talking to patients, by talking to families, by talking and asking questions about the things you see listed on the screen. How's your speech? How's your swallowing? How's your handwriting? Can you cut your food and handle a knife and a fork? How do you do with getting dressed and walking? Are you falling? Are you passing out? Urinary function, sexual function, bowel function. We're not asking you these questions because we want to pry into your personal life, but because these are all potential symptoms of MSA, and we want to see how affected a person is, and we want to be able to follow how affected a person is over time. So all of these things that we ask are rated on a scale of 0 to 4. So 0 meaning you have no trouble with it, and 4 meaning it's pretty much impossible. So falling, for example, 0, you don't ever fall, and 4, you really can't even stand up without falling. So we add all these numbers up and we get scores for each part of it. The second part is the examination. So this is the doctor going over you, looking at your facial expression, looking at your eye movements, assessing your speech, watching you touch your nose and touch their finger and do finger tapping, and getting up and walking and trying to knock you over to see if you can maintain your balance. All of those things as well are graded on a scale of 0 to 4. 0 meaning that it's completely normal, 4 meaning that it's almost impossible. And then the third part is the orthostatic vital signs. So we look at heart rate, we look at blood pressure when you're lying down, when you're sitting, and when you're standing. And then the last part is on a scale to 5 of disability. So the lower number would be that you don't have any trouble doing anything, you don't need any help. The higher number would be that you need help with everything that you need to do. So this is something that sometimes doctors will do this when you're in the office at a routine visit. Most people will not. But in terms of clinical trials, this is the rating scale that everybody uses so that we're all sort of following things in the same way, and we have a common way of assessing how drugs work. So now I'm just going to go over fairly briefly a bunch of things that have been in clinical trials recently, some things that are coming up in clinical trials. I do want to say that there's not a lot of encouraging information here, but this sort of list is partially to show you that MSA is not a forgotten disease, that there are plenty of investigators working on MSA, looking to see if we could find compounds that will help with some of the symptoms. So lithium, I start with this one first because I hate this drug, so I figured I'd get it over with first. Lithium is a drug that is most commonly used to treat bipolar disorder. So it really helps significantly with people who are manic and tones them down so that they can be on an even keel. And patients who take it for that love it because it can work really, really well. But as a movement disorder doctor, lithium causes a lot of movement disorders that then I see patients on it and I have to tell them that it's from their lithium, so that's partly why I hate it. It also can affect your kidneys, but there have been clinical trials looking at lithium in a variety of different neurodegenerative diseases. MSA is not the only one. It was studied in ALS, or Lou Gehrig's disease, as well. And actually in both of those conditions it was found that the patients couldn't tolerate it because it has a lot of side effects, and so the studies were stopped and not continued. But this study looked at lithium in a dose up to 1,500 milligrams a day, and the patients really did worse. Lithium can cause tremor, lithium can cause Parkinsonism, lithium can cause involuntary extra movements. So lithium is probably not something that people would be recommending to take for MSA in the future. Rifampacin is a drug that is FDA approved for the treatment of Parkinson's disease. It's FDA approved for early Parkinson's disease as well as later Parkinson's disease. And Rifampacin works on a compound in your brain called monoamine oxidase type B. That is an enzyme in your brain that helps to break down dopamine in your brain. So you heard this morning that part of the problem in patients with MSA, in the brains of patients with MSA, is that the cells that make dopamine die off, and so there is a dopamine deficiency in the brain. The thought was that if you used Rifampacin, which would allow your brain's own natural dopamine to stick around a little bit longer, that it would help with symptoms of the Parkinsonism associated with MSA. And in mouse models of MSA, it also seemed to show reductions in the amount of brain cells that died off over time. So there was a thought that maybe there would be some slowing of the progression of the disease in humans, as well as improvement in their motor function, improvement in the Parkinsonism. So the study was done with just patients who had MSAP. In other words, Parkinsonism as the predominant motor feature, not ataxia. And they had to be able to walk to participate in the study. And the primary outcome measure was the change in the score of the MSA rating scale. So that's what we look at, those numbers. The lower the number is, the better you're functioning. The higher the number, the worse you're functioning. So we were looking at how much did it change over time to see if there was less change in the group that was treated versus the group that was given the placebo effect. And what we found in that trial was that there was no benefit in treating patients with MSA with Rifampacin. So here you can see what sort of, this is only 2 trials that we talked about so far, but a lot of what you do in clinical trials when there isn't a drug specifically for the condition that you want to treat is you try and piggyback on drugs that are used to treat other conditions, drugs that are already on the market, drugs that are more easily accessible, drugs that you know something about the pharmacology of and the safety of, and you try them on a condition that they may not be FDA approved for to see if they can help. When we were talking about bladder issues earlier this morning, you saw that a lot of those things that can be done to help with bladder dysfunction, they're not FDA approved for MSA per se, but it's clear that they help in other people that have similar kinds of bladder dysfunction, so the urologists use them to help the problems that we see in MSA. And so that's, again, what we try to do here. We look at drugs that treat Parkinson's disease and see if they'll help with the Parkinsonism aspect of MSA. We look at blood pressure drugs that may be used for other things, not specifically for MSA, but drugs that we know that can elevate the blood pressure, and try them to see if they will help to elevate the blood pressure in people with orthostatic hypotension from MSA. The next drug, again, is another drug that has been on the market that was not designed specifically for MSA. It's called Rifampacin. And Rifampacin is an antibiotic. It's on the market as an antibiotic. It's used to treat certain infections. But what Rifampacin does, if you look at it in sort of the laboratory, if you look at it a little bit more closely, is that it can reduce the accumulation of alpha-synuclein, which is something that aggregates in the brains of people with MSA. There are a whole bunch of conditions that are neurodegenerative diseases where brain cells die out because of too much of this alpha-synuclein. The alpha-synuclein, for some reason, it clumps all together and it messes up the way cells work. And that makes the cells malfunction, and that makes cells die off. So if we could do something to stop this from happening in this group of conditions, which I'll call synucleinopathies, there's something wrong with the way the alpha-synuclein folds up in the cell and it clumps all together and makes a mess, then we could potentially slow the progression of the disease and treat the disease. So it was thought that Rifampacin may do this, may reduce that aggregation and be able to slow down the progression of the disease. So there is a study that will be underway soon to study rifampacin in patients with MSA. They're going to look at safety, which we always look at. They're going to look at tolerability, so whether it causes any problems, whether patients have any side effects from it, as well as whether it actually helps. The dose that will be used is 300 milligrams twice a day, and the endpoint will be the change in that rating scale after a year. So we'll follow people for a year and see what happens to their rating scale numbers, whether they stay the same, whether they continue to decrease, and whether they have any side effects. Rifampacin is now, a lot of these drugs that are on the market, I don't want you all sort of writing them down and saying, okay, I'm going to go back to my doctor and I'm going to tell them to put me on this medicine because, look, it's going to be studied and I should take it now. The reason that we do clinical trials, and the reason, especially with a drug like rifampacin, is to look at safety. These are not all the safest drugs in the whole wide world, and some of them need monitoring. You need to watch out for certain side effects. So that's why participation in a clinical trial allows you to be monitored to make sure those side effects don't develop, because if people take these medicines, I'm going to use lithium for an example. Suppose you get your doctor to put you on lithium, but they never check your lithium levels. Lithium can damage your kidneys. Lithium can cause renal failure. If a doctor just writes you the prescription and lets you go take it in a huge dose because that's what's being studied, and then you never get monitored and you end up with renal failure, that's not a good thing. So the clinical trials need to be done so that the appropriate safety precautions can be taken, so that we know if it's safe, and so that we make sure that we monitor everything that needs to be monitored. There are other compounds out there that are safer, where it doesn't really matter, but these drugs that I'm talking about here, they need to be monitored, and you don't want to just run out and try taking them on your own just because they are in clinical trials for a condition that you'd really like to treat. Riluzole is another drug that is on the market. This drug is FDA approved for the treatment of Lou Gehrig's disease, or ALS. And this has also been studied, and you heard reference to this morning as well, was studied in a big trial to see if it would improve the symptoms of MSA, and it did not actually help either. But this is a relatively safe drug to use. There was another trial of riluzole done in Europe looking at both MSA and PSP patients. That was a larger scale trial. Again, not a really helpful medication, so don't ask your doctors to put you on that. This is a new drug that will be may be useful in the treatment of orthostatic hypotension. Studies are going on to look at that. Orthostatic hypotension is nice to look at as an endpoint because blood pressure readings are really clear. When we talked about the MSA rating scale, a lot of that is subjective. It's based on you telling me how you're doing. Some patients aren't honest with their doctors all the time. Sometimes they don't want to tell you really how often they fall. They don't want to tell you how often they have urinary accidents, so that the historical part of it is a little bit biased because they don't want to look bad, or they want you to feel like things are better than they are. But blood pressure, you can't really do anything voluntarily to change your blood pressure. When you're sitting in the doctor's office, what is measured on the cuff is what your blood pressure is. So we have a nice objective measure of whether the blood pressure is dropping when you stand up or it's not. So this is a new medicine that will be in clinical trials for orthostatic hypotension. Minocycline is another antibiotic that, again, you'll see a lot of these drugs that are in clinical trials for MSA are drugs that have also been in clinical trials for other neurodegenerative conditions. So riluzole, for example, it's FDA approved for Lou Gehrig's disease. It's been studied in Huntington's disease. It's been studied in Parkinson's disease. Minocycline, the same thing. It's an FDA-approved antibiotic, had been tried in Huntington's disease, Parkinson's disease, Lou Gehrig's disease. We go through the same pattern over and over again, hoping that these drugs will work in one or the other. So this study was a study looking at 63 patients. Some of them got minocycline, some of them got placebo. And again, we just looked at the motor part now. This is the examination part of the MSA rating scale from the baseline visit, so before they were started on any medication, till 48 weeks after they had been on the medication. And they also looked at it at 24 weeks after they had been on the medication. And what they found is that in both groups, the placebo-treated group and the minocycline-treated group, their motor scores went down or went up. They got worse. And so there was no difference, actually, between the two groups. The progression was the same in both groups of patients, whether they got the minocycline or whether they got the placebo medication. So minocycline has been thrown out as a treatment for MSA. Now, this is a study looking at fluoxetine, which is an antidepressant medication. And this was looking at a mouse model of MSA, so sort of going backwards now. We were talking about a lot of human trials before. Now we're talking about an animal study. And what they found was that fluoxetine lessened the motor symptoms in mice. And when they looked at the mouse brains after the study was done, it also seemed like there was less neurodegeneration in the mouse brains of the mice, I was going to say patients, the mice that were treated with fluoxetine. So this, again, using a common medicine for a different therapy, for a different disease state to see if it actually works. So that will be studied in patients as well. And there was a study, actually, that I didn't put up here, looking at fluoxetine in stridor for patients with MSA. We'll hear a little bit more about this later. But breathing can be a problem, that there's a real kind of respiratory issue in MSA, and there isn't a lot that can be done for that, but there was a very, very brief publication, actually I just read, I think maybe 3 patients, so not many patients, but looking at the same drug and finding that it was helpful in that. So that is something that, you know, patients can. One of the things, I mean, we don't really talk about things that can hasten death in multiple system atrophy, but one of them is a real respiratory compromise, which if we had medicines that would help with that, that would be wonderful. And it may be, when bigger trials are done, that we may see some effect of fluoxetine. Droxidopa, which I know the Chelsea people are here, is a drug that was studied to treat orthostatic hypotension. It is a drug that has been on the market in Japan for many, many years to treat orthostatic hypotension, but the FDA has not been willing to approve it in this country just yet. It is a good drug for the treatment of orthostatic hypotension in people with neurogenic orthostatic hypotension, primary autonomic failure, multiple system atrophy, but it is still waiting on FDA approval. So this is a drug that hopefully at some point we will be able to use a little bit more freely. And finally, I saved the stem cells for last because everybody wants to know about stem cells. And stem cells get such big press. But stem cells have been studied in MSA, and stem cells are primitive cells. Stem cells are cells that have the potential to differentiate into or to turn into other types of cells. So they're immature cells that then can go on to grow into all different kinds of cell types. The way most of the stem cells in our bodies now are in our bone marrow. We have very immature cells in our bone marrow as well as more mature cells in our bone marrow that typically grow into red blood cells and white blood cells. But the immature cells can grow into other types of cells as well. So they can keep making more and more cells, and they can turn into cells of different kind of cell types. So you can turn one of those bone marrow stem cells into a fat cell, into a heart cell, into a bone cell, into all different kinds of cells. And the nice thing about using this type of stem cell is that you can get it from yourself. You can use your own stem cells. One of the problems that we had in terms of trying to use immature cells to try and grow new brain cells for people is, we'll go back to Parkinson's disease for a minute, is that one of the best sources of immature brain cells, cells that can differentiate into brain cells, are embryos. And the use of embryonic tissue is really filled with controversy. And it also is not something that you can use for the number of people that would potentially use it. It just is too much. You need some kind of a cell that either you can give it to yourself, like if you're going for a hip replacement, you would donate some of your own blood so you could have a blood transfusion during your hip replacement, and you give yourself what you need. Or something that you can grow in a laboratory easily, so that if I want some stem cells to treat whatever it is that I want to treat, then I can call up the laboratory that grows them, and they can send me a little vial of stem cells, and I can use that for my patients, and I don't have to worry about any ethical considerations involving embryos or where the tissue comes from. They just come from a nice laboratory and just keep growing and growing and growing. So what's nice about using this type of stem cell is that you can use your own, and that doesn't really have any kind of ethical considerations that other types of immature cells have. So this is just a little picture looking at mesenchymal stem cells in the middle, and you can see that those type of stem cells can differentiate into all different kinds of cells. They can make you some tendons, they can make you some new skin, they can make you some new muscles, and maybe they can make you some new brain cells. So this has been looked at in MSA. This is a very small study. They looked at 3 patients, and they looked at people in this study with MSAC, so the cerebellar type of multiple system atrophy. And they gave them their own stem cells. The first injection, they had 4 injections over the course of the study. The first injection was intra-arterial, so they put it into their artery. The second 3 injections were intravenous, and then they followed them for a period of time to see what would happen to their symptoms. And what they found after a year was that there weren't any side effects from the medicine or from the stem cell injections, except for the fact that they felt that the intra-arterial injection, sometimes on the MRI scan, remember the MRI scan that Dr. Golby showed with a little stroke in it, that you can see some areas of ischemia, decreased blood flow from injecting something intra-arterially, but that didn't cause any functional side effects in the patients. And they also seemed to show that there was less cell degeneration, less brain cell degeneration in the group that was treated with the stem cells versus the group that was not. It is possible, this study is only 33 patients, is a very, very, very small study, that this may be something that we can look at in the future to see if it could potentially slow down the progression of the disease. There are stem cell therapies, as I think one of the questions was there this morning about stem cell therapies and whether that is potentially curative for conditions like multisystem atrophy. If you could, in theory, give some kind of a stem cell that would grow and replace all the cells that have been damaged by MSA, then you could potentially fix a lot of the symptoms. But what you haven't done by injecting those stem cells is do anything to the underlying disease process. And what we do know from at least Parkinson's research, where we have long-term follow-up of people that have had stem cells, embryonic stem cells, transplanted into their brains, is that if you wait long enough, the disease process will affect the cells that you inject there. Now, there's nothing wrong if I could say that I'm going to inject you with some stem cells now, and it's going to make you feel good for the next 10 years. But 10 years from now, the MSA is going to start eating away at those cells. So then you might have to go back and have some more cells injected. I'm sure you would all say, let me have it, that would be fine. But the truth is that until we understand what makes those cells die off in the first place, that these kinds of therapies are going to be sort of temporary measures. They're going to help you for a period of time, assuming that they really work the way we want them to. But then the disease is going to start affecting those cells as well. So we need to improve our understanding of what is actually going wrong and do something to stop that so that we can really stop the progression of the disease. The other thing that we didn't talk about, which hasn't been studied so much in MSA per se, but is definitely being studied in other things, is what's called gene therapy. Gene therapy is where you don't use stem cells, you don't use immature cells to get information into the brain, but you use a virus. And you use a virus that likes to go to the brain, because some viruses are very good. They target certain cells, and they attach to those cells, and then they spit out all their genetic information into those cells, and they make them malfunction, and they make you sick. But what they can do in the laboratory is take all the virus genetic information out of the virus, but still leave the outside of the virus, which likes to go to a specific cell type. And then they put in genetic information that we want that cell type to have. So say it was something simple like making dopamine, okay? And we decide that we want to put like the genetic information for how to make dopamine into this virus and send it into your brain, and then it goes into your brain cells, and that genetic information is released so that those cells that were targeted by the virus are now going to have the information or the plan of how to make you some dopamine. So they would turn into dopamine-producing cells. That kind of stuff is applicable to things like cystic fibrosis, where you're missing an enzyme. You put the genetic information for that enzyme into a virus that wants to go to lung cells, because that's what cystic fibrosis affects. It releases that information, the lung cells can make what they need to make, and you breathe easier for years and years and years. So that's one way that we get genetic information into different cells in our body, is by taking the bad viral stuff out of the virus, but using the fact that the virus likes to go to certain parts of our body, certain cell types in our body, and then we can get the genetic information that we think to those cells so that we can make the person function better. Now, this is something that is starting to be applied to different neurodegenerative conditions. MSA has a little bit of a more complicated picture than some. Cystic fibrosis, the deficit is, I'm not going to say the deficit is easy to fix, but it's just one thing. MSA is a lot of different parts of your nervous system. It's your cerebellum, it's your basal ganglia, it's your autonomic nervous system. So you might need a bunch of different genes to be targeted, a bunch of different cell types to be targeted in order to fix the symptoms of that disease. But this is technology that is available right now, and is starting to be applied to a lot of different neurodegenerative conditions. So I think that you will potentially see more information about that in the future. So if you're interested in clinical trials for multiple system atrophy, there are a lot of resources. I typically recommend clinicaltrials.gov, which is a website that has NIH-sponsored trials as well as other trials on there. There are multiple system atrophy study groups. There's a North American multiple system atrophy study group. There's a European multiple system atrophy study group. So those are good websites as well. You have the MSA Society that has a little research thing on their website as well. So there are lots of places to look for clinical trials. I think if the research is something that you're interested in, it is really important that you ask your doctor if there are clinical trials going on locally. If there are not, are there some that are recruiting that you would be a candidate for participation in? Because participation in research it's really is a good thing to do, and it's how we learn whether drugs work or whether they don't. And sometimes knowing that a drug doesn't work is just as important as knowing that a drug does. We have used coenzyme Q10, which is all the rage in a lot of different conditions. It has been studied in Parkinson's disease and Huntington's disease and Lou Gehrig's disease. Coenzyme Q10 is something that is in every cell in your body. It helps your cells make energy. So if your cells are dying off too soon because you have some neurodegenerative disease, then perhaps taking coenzyme Q10 would give them more energy and help them be able to fight longer and survive longer. So this has been used to try and slow down the progression of a number of different conditions. But the doses that are used to slow down these conditions are really, really high. And so if you thought, well, they're studying it, I should go take it, and I can buy it at the supermarket, you're going to be spending hundreds of dollars a month to pay for that drug. And even though it's not going to hurt you physically, hundreds of dollars a month would buy you a nice dinner, would buy you a nice weekend down the shore, would buy you something fun. So if it doesn't work, then there's no reason for you to be spending your money. So I think that information, even if we find out sometimes that the drug doesn't work, it allows us to say to people, don't waste your money on this, don't waste your time on that, really concentrate on other things like exercise. So I'm gonna turn this over to Joellen, and we'll have time for questions later.
Great, thanks. To say we've got a couple questions, but one of them might better be answered right now because it's so short. It's just kind of like a yes or no. We know that Rifampacin has been in trials for MSA for a year. Are you referring in your talk to this study, or is there a second study going on?
There is another study that is set to start.
Okay, thank you. We'll have more questions for you during the question and answer period. Thanks so much.